It is my absolute pleasure to introduce Dr. Sherry Yafai, who I just met in 3 dimensions for the first time today, but we've been, I think, like schmoozing now for like 2 years. So such a pleasure to have her come from California. Sherry Yafai, MD, is a cannabis and board-certified emergency medicine physician since 2009. Dr. Yafai started her medical career at UCSD Medical School, graduated in 2005, and UCSD Emergency Medicine residency in 2009. In 2017, after recreational marijuana laws had passed in California, Dr. Yafai opened her private cannabis clinic, the Relief Institute, where she sees patients referred by physicians for cannabis education and treatment. She is the past co-vice president of the Society of Cannabis Clinicians and a distinguished speaker for UCSD Center for Medical Cannabis Research, Pacific Neuroscience Institute, and multiple other medical programs. In 2019, Dr. Yafai worked with the Los Angeles community to put together the first CME-approved medical cannabis conference designed to educate the healthcare community on dosings, indications, and legal perspectives in the recreationally legal setting of California. The Relief Institute conference hosted the Medical Board of California, the LA County of Public Health, the Department of Cannabis Regulations for LA, Clinical and Cannabinoids Research Journal, and SCC. At the start of 2021, Dr. Yafai took on a new position as the Senior Vice President of Medical Affairs at People Science, with research on the current market as its focus. Currently, People Science's first research project on sleep and THC is underway and accepting volunteers in the local Los Angeles area. A second research project is underway at Pacific Neuroscience in Santa Monica, focusing on cannabis education and dementia patients. This group is also currently accepting volunteers. It is my great pleasure to introduce Dr. Sherry Yafai, our keynote speaker.
That was a long list. I swear, it's not that exciting. Hold on one second. This is my Paloma. Tell me, how do I use?
The green button? Green button.
Okay. All right. Sorry. Some technical difficulties here. So thank you. I think I've been talking all day a little bit here and there, but thank you for having me. This has been a very exciting day. I wanted to just... Let's see if we can do this here, if I can move it forward. All right, looking forward. So I wanted to talk today specifically about medical cannabis laws and how they've changed in California, how it's gone forward, how it's and how we have recently gotten into recreational laws. And by recent, I mean in the last 5 years. So you've already heard a little bit about me. I am an ER doctor. COVID changed my medical practice to go from being in the ER solely to going to urgent care practice. So now I do both urgent care and I run my own full-time cannabis office. In the last decade, I have also kind of moved around here and there and done a couple other exciting things in the world of cannabis, including medical education with the Society of Cannabis Clinicians. I worked with a rehab group called High Sobriety that allowed for cannabis use as a means to get past the withdrawal phase of opiate reduction and opiate removal. During this time, I've become also just 2 or 3 quick disclosures. I am a paid medical director for an in-home infusion company. I've been paid from a YouTube channel called WowWee TV. It's very exciting. And other than that, I've been a medical expert for a couple of cannabis cases. I can tell you briefly about them. They had to do with driving and testing positive for THC. And we won that case. And the other one had to do with pain management. All right, so California changed over to medical. It was the first medical state, right, medical cannabis state out of all 50 states back in 1996. This started in California really because of the HIV epidemic. And since that time in 1996, what we found was that medical was really just very quasi-medical. It wasn't really medical. It felt like it wasn't really medical because for 26 years, It was put your head in the sand, and most doctors didn't know what it was all about. A handful of physicians were the only ones that were actually working on doing the medical recs. Is someone going to do that for me back there? Sorry. Thank you. Okay, you could just flip through all of those for me real quick. So 26 years ago, it legalized medically, but most people were not doing it. Most people were just giving a stamp of approval. There was no guidance being given. I call this rubber stamping. It was a 5-minute appointment. Nobody talked to you about any questions. And if you had any questions, you didn't direct it to the medical doctor. You directed it to the bud tender behind the counter, right? That's really what it was going on for the last 25 years. And I'll tell you, how do I know this? Because I decided one day to go and explore. And I went to one of these medical providers who barely looked at me, barely addressed me, told me to circle where it hurt on my body picture on the chart, and then said goodbye and handed me a rec. And I was floored that this is what we're doing for our cancer patients, that this is what we're doing for our pain patients, that we're not providing them with any education whatsoever. And so what happens? This is what happens. This is what our medical marijuana marketplace looked like for 20 years in California. It looked like a pager store that had all the pagers removed. Remember, everyone here is of pager age. All the pagers were removed out of the store display shelves and pot was put in to replace it. It was hidden. It was cloaked. There wasn't anybody talking about it. There was nobody educating about it. If there was a green plus sign in the window, that's how you knew it was a dispensary. Okay? There was security at the front door. It was generally all cash, so nobody would go in. These were oftentimes being robbed because the security wasn't that great, and it was a big cash business. Next. So, options were limited to just flower with fewer other options, and there was no testing or labeling beyond names, right? And this is where we really used a lot of the words like indica, sativa, hybrid. That was coming from the 90s and the early 2000s. Have you noticed none of us have really remarked about indica or sativa here today, or hybrid? There's a reason, because it's not really very medical, right? It's very subjective. It's like talking about a glass of wine and saying, oh, this is a very earthy tone to it. I'm not very good at those names. So what is a physician to do? Back in the day when it was medical only, we didn't really have a lot of CME type events like this, right? We had see one, do one, teach one. Get educated, practice, and then teach. And so that's exactly what I did. I started off with education, and I went and joined the Society of Cannabis Clinicians. For those of you who don't know what Society of Cannabis Clinicians is, it's an organization that is based on education that is formed mostly by physicians, by nurses, by pharmacists. We are now international at this point, and we are on, I believe, 3 continents. We've got about 500 members, and the focus and goal of this organization is education, education, education. We are a nonprofit organization. I used to sit as the co-vice president. I believe I'm now the secretary at this point. They've handed me another role to do stuff for them. And what we're trying to focus in on now is educational modules so that people can learn about these things at home at their own time.
Also, it's inexpensive to join that.
Correct.
It's $200 for the year.
Correct.
Which is nice.
That's exactly right. I'm still not able to change this. Okay, here we go. So this is the SEC board. And these are the educational modules I was talking about. So there's about 24 modules. They're not expensive. They're each about an hour long, and they've been really well designed so that you can get the best research that's out there and learn about them. And in fact, it's so well done that I've got one of them done too. Just kidding. I've done the cannabis and pain module. You'll see down on the bottom right-hand corner. I don't make any money off of this, just so you all know. It goes directly back to the society to continue promoting education. All right. But what we've done here is taken all of the lessons learned and all of the research out there and really compounded it to each specific topic. So what happened? What happened between 1996 and 2016? Duh, everybody likes weed. Right, this is not a huge step or a huge leap here. People like weed. So 2016, we now found that recreational got legalized. And then something else happened in California, which I don't know that everybody here knows about. In September, we passed a new law. It's called Ryan's Law. And Ryan's Law basically has allowed us to use cannabis for hospice patients within the healthcare setting. What does that mean? It means that patients who are using THC for pain management can now use it inside the hospital. This is very specific to hospice patients. Does anybody know why this happened, or what? Anybody saw the viral video? What was it? Do you remember?
A young man didn't have access to the medicine.
That's right. And do you remember what happened? So I'm going to repeat it in just a moment.
What happened?
Did you see the police come and arrest him? So a young, let's say middle-aged man with pancreatic cancer is in the hospital and is using cannabis products in order to manage his pain, and the police get called and come and arrest him. This video went viral, and because of this video, we passed a new law, right, that says that it's okay if you continue using the medicine that you've been using at home for pain management at the end of your life in the hospital. We won't come and arrest you anymore, right? Really important stuff. So what happens next? If we legalized in 2017, what happened? We went from saying just say no, right? Everybody in this room is part of the DARE program at some point in their lives, to just say no, no problem, right? You can have whatever you want. You can do whatever you want. We found lines around the corner for recreational dispensaries at the very beginning, sometimes during the holidays too now. There's no dramatic increases in car accidents that's happened. There's been no dramatic increases in ER visits, but there has been some increase in poison control calls, right? People take too much of an edible is the most common cause. They call poison control. Poison control tells them to take a nap. Right? Everybody here knows that's exactly what happens. The other really interesting part that changed was pot doc shops closed. What does that mean? Pot docs are what I lovingly refer to my colleagues who have chosen to go and rubber stamp an approval without talking to patients. These are those approvals that I was talking about at the beginning that were very much akin to our medical, not Minnesota's medical, but our medical environment for 20 years. They were the ones that were rubber stamping the approvals under the guise of medical, but it was really, let's just hand out cannabis to whoever comes seeking it. And they closed by about 70 to 80%. So in Venice Boulevard in Los Angeles, it's a very popular tourist spot, you would see a line of these pot doc shops. Those have now all closed. So what happened? Did we now get this new separation between medical and recreational? Do we now have this perfect fit where medical patients can go to the medical shops and recreational patients can go to the recreational shops? No. In fact, we have nothing even close. There's no physical difference between medical and recreational stores in California. All of these shops are one and the same. Why is that? Because if you apply for one license in California, you get both. So if you apply for a medical license, you will get a recreational license as well. If you apply for a recreational license, you will get a medical license as well. Early on, I can't quote you right now what those prices are, but early on it was about $100,000 for the application for one of those licenses. It's a lot, right, just to apply and sometimes get denied. So are there any physical differences between the products in California? Nope. These are technically all the same products. They are all being sold equivalently. When the rules went down in California, they said, oh, for medical, you can have a 10 milligram per gummy or per edible dose of THC. And for non-medical, for recreational, you can have a 5 milligram dose. Guess what you see in every single product in every single store? A 5 milligram dose. So you see a 5 milligram dose everywhere, except some products have now gotten creative and they call one gummy 2 servings. So a half serving is 5 milligrams. So there's ways to get around these rules, right? These companies get pretty darn creative. And what ends up happening is there's nothing really more exciting about what's medical versus what's recreational. The next problem. People can walk into these shops and get as much as they want. So imagine going to a liquor store and buying 10 bottles of vodka, 5 bottles of tequila, 2 dozen beers. I don't know, whatever. It's the same thing that they do here, right? It's the exact same thing. You can buy however much you want, so it doesn't really matter. There's also no limit on the THC in the smoked variety. So this is something like Delta-8 THC that was unexpected, right? Before, you could only get flower that was about 25 to 28% THC. Vapes were not really around at the time when recreational laws went into play. Now they are, and through creative chemical engineering, you can get flower that's about 33% at this point in time in California, and you can get vape pens that are 99% THC. It's a lot. So, the beauty of recreational came this new concept that cannabis is actually medicine. So imagine that we did it all backwards. We really did in California. And it's because it was the first and we were kind of the guinea pigs for everyone. Since recreational laws have gone into play, all of a sudden every major university in California has a research institution dedicated to cannabis. UCLA has now opened up the Cannabis Research Institute. UC San Diego has had one for about 20 years. UC Irvine now has one. UC Berkeley has one. And UC Santa Barbara is starting one, I believe. There's now new medical journals dedicated to cannabis research. Cannabis and Cannabinoids Research Journal is now available online, and it's been going on for the last 4 years. And guess what? That was started at UC Irvine after recreational legalization. CMEs now abound. Look what we're doing here today. This is the beginning of a lot of CMEs, right? You're now starting to see this where before we never had it in residency, we never had it in any sort of our education programs. We now have an emergency medicine news column that I started because I was tired of reading about cannabis hyperemesis syndrome. How much can we talk about CHS when we talk about cannabis? It's not that bad. And by the way, if we're going to play equal, then we also need to talk about opiate death every time we talk about opiates, right? But we don't, because that's not the only reason to talk about opiates. And it's not the only reason to talk about cannabis. So we need to have equal discussions both about the positives and the negatives. And of course, the internet. The internet has literally exploded with cannabis. Websites, hemp websites, information, discussions, High Times, Marijuana News Daily. I mean, you name it, and you can find it now on social media sites, on Facebook pages with patient groups that are dedicated to cannabis. I think I'm a part of like fibromyalgia for CBD for fibromyalgia, or cannabis for ulcerative colitis. There's all of these different ones out there, and they're all discussing it. So guess what? You need to be the smartest person in the room when a patient shows up, right? So you have to know about these different things that are out there and available. So basically, medical marijuana actually emerged in California once we had recreational laws. It's a bit surprising. But now what they finally want is more than a stamp of approval. They want guidance and coaching. They want a 45 to 60-minute appointment to have a real discussion and talk to you about what's really bothering them. They want more than just go smoke a joint and call me tomorrow morning. They don't want that. That's not what they're interested in. They want real medical advice. You can take this and apply it to a wellness and holistic approach. This is what a lot more individuals are looking for. They're looking for plant-based medicine. They're looking for Eastern type medicine. They're looking for vitamins and holistic support, right? They've read and heard so much about pharmaceuticals being problematic that they want to lay off the pharmaceuticals. And again, the internet has changed the information that is at our patients' fingertips. So if the internet has changed, we can't say you can't show up to the emergency department if you've gone through Google and self-diagnosed your appendicitis. Right? I can't say that. I'm actually very happy when people go on Google and decide that they need to come to the hospital because they finally realize that there's something really critically wrong with themselves. I have to contend with that sometimes by saying, you know what, you don't have cancer, you just have diarrhea. It's okay. Sometimes that's what we get paid for, right? To come up with the real solutions and the real diagnoses. But you also have to realize that they're going to go on Google, They've already looked up THC and CBD. They've already decided that this may be beneficial for them or not. Oftentimes people will come in and say, I do not want any THC. I only want CBD and I don't want to get high. And then I have to talk to them about the real benefits of THC and neuropathic pain. So this is something that you have to be really smart about because your patients are smarter. So remember how I showed you the recreational marketplace back in the 90s and early 2000s? You guys have it lucky out here, by the way. Your marketplace is already nicer than this. Here's what they look like now. These places are beautiful, right? The recreational marketplace has upped their game. If they're gonna spend $100,000 on just a license, you better bet that they've got a lot more money and a lot deeper pockets to make really nice places to lure people in, right? And I'm saying that a little bit facetiously. We love our cannabis providers, but at the same time, they're not in this for the patient benefits, right? They're in this for the money. These cannabis dispensaries are now being featured. This one was in Architectural Digest, right? This is not your mom and pop version of cannabis anymore. They're catering to the Apple-style consumer and marketplace. They're advertising this to all ages. Let me repeat that. All ages. This is not just for you and me and anybody who's an adult sitting in this room. Everybody in this room has parents at some point or another. Some of them are still alive. And guess what? Oftentimes you're gonna go back and tell your parents, hey, Mom, your arthritis is bothering you. I heard cannabis can make you feel better. Let's go figure this out. You are the same demographic of people that come into my office and bring their parents into the office. You're also the same demographic that has children, that bring their children into the office for autism, ADHD, cerebral palsy, you name it, I've seen it, cancer, unfortunately. These are the people that everyone is getting advertised to, okay? So you have to know that this is coming and you better be aware about it. So what are the advantages of this legal recreational marketplace? Easy. There's such better regulations now. So much better than ever before. And not just that, but the requirements for testing and labeling is much better. There's more consistent products out there on the market. And these are now in California, and I believe Colorado, are requiring it to be pediatric or tamper-proof. Because there were a handful of cases where kids got into gummies that looked like gummies that shouldn't have, and they landed in the ER and were hospitalized. This is an important advantage. We now have more product, more access, and more choices than ever before. You walk into a store and you're gonna be overwhelmed. So what's the disadvantages of the legal marketplace? You have more access, more choice, and more availability than ever before. People are overwhelmed. They don't know where to start. They think that just because it's legal now, recreationally, they can walk into a store and figure it out themselves. I thought so. I thought learning about cannabis would take me a week. I figured I'd go into a dispensary and learn about what tastes good, smells good, feels good, and that would be the end of it. It took me months to get to a point where I felt comfortable. And after 6 months of educating myself and shadowing another clinician, I finally took on one patient. One, after 6 months. It took me another year to figure out how to do this well and how to do it consistently well. So what is another disadvantage? If everybody has access to everything and anything, we get increases in accidental ingestion. Now, when I say overdose, people freak out and they think that I'm saying they're gonna die. No, the technical term is an accidental overdose that can land people in the emergency department less often. Most people end up calling poison control and they don't feel well. They stay home, they sleep it off, they may throw up, and they call it a day. But the problem is that we can do it better for patients, right? They don't have to go through this. Just like you don't have to go through an accidental overdose at home of any other medication because you're educated about it. We've seen increases in cannabis hyperemesis syndrome, and we've also seen increased use, presumably in college-age kids. The problem that I wanted to draw everyone's attention to here today, though, is the problem that it has left us in the medical world. because we have more access, because more people are interested in it, because more people are using it without the false cape or the cloak of wanting to get high, right? The recreational market abounds, and it's putting a squeeze on our medical marketplace. What does that mean? It means that medications that work best for patients and not for getting stoned tend to be quickly taken off the shelves. They tend to be discontinued and harder to find. The most vulnerable patients get financially de-incentivized. So we've said this a number of times today, but the doctor visits may or may not be covered by insurance. I take cash only. I don't charge insurance because of obvious federal rules. Your medication cost is not covered by insurance. And then on top of that, it's taxed at about 30% right now in California. So if a patient spends $100 on medication every 2 weeks to 4 weeks, add another $30 just in taxes. It's crazy. So now somebody who is in a wheelchair, in hospice, not able to afford a whole lot because they're at the end of their lives, now has to spend anywhere from another $200 to $400 for medication a month alone. It's a lot to ask. So what's the general public's perspective on all of this? More availability means more, why not try attitude, right? Let's just go for it. More adults suggesting seniors and pediatric patients try, as we've discussed. More sharing with vulnerable patients and patients in need. So oftentimes I'll have cancer patients come and say, they can open up their purses and dump it on the table, and they say, well, my friends gave me all of these things, but I don't know what to use or how to use it. And there's more press and publicity in all walks of life. It's gotten to a point in Los Angeles where there are now billboards almost along all major roadways on cannabis. And I have to tell my kids hear me use the word cannabis all the time. They hear me use the word THC and CBD all the time. I don't think it's appropriate for them to use. I don't think it's appropriate for neurotypical kids to be using this stuff. But now I have to contend with the publicity around it to tell them what this stuff is. And why is it that it's on a billboard and it looks like fun? How come I can't use it? Or how come this is not for me? And then there was a recent large article in AARP. Is anybody a part of AARP yet? All right, we see a couple of hand raising. Did you guys see the article? No? All right, I'm going to show you part of it here in just a moment. But basically, more availability means more interest in getting cannabis for medical purposes. And that's going to translate to getting more patients. And more patients at more dispensaries means that the expectation is for a pharmacist or physician to discuss it. If it's medical, then doesn't that mean somebody in the medical profession should be telling me about it? It's not exactly what's happening. This is more in tune with what's happening. And remember, this is a cartoonist making this up, right? Not for this lecture, but to really dive into what's actually happening in the world, which is that at a drug dispensary or pharmacy, there's multiple layers of problems, right? That's what that's really describing. And at a dispensary for marijuana or cannabis use, the problem is there's no discussion. Patients expect that the bud tenders are trained providers. We do not have pharmacists that are dispensing this in California. We have bud tenders who are akin to fast food workers, and patients ask them, what should I use for sleep? What should I use for pain? What should I use? How do I dose this stuff? What are the ratios I should use? The person behind the counter may or may not be experienced, but legally they're actually not allowed to discuss medical dosing with patients. And to my unhappiness recently, I learned that the turnover for bud tenders is about similar to fast food chain turnover. We were running a study with People Science on sleep and THC products at a very big dispensary in Los Angeles, and we couldn't get appropriate feedback from the dispensary about who was enrolling in our study, because every time we turned around there was a new bud tender. So we'd have to train someone new to write down the patient's name, to write down the information so that we could get it enrolled in the study. It was kind of crazy. So this level of false expectation is really a big problem right now. And we're seeing this not just in California, but in other states as well. So this famous AARP article I was talking about. So marijuana, medical marijuana, your questions answered, and what we know today. What do we know? We know that there is minimal medical input. Remember, AARP is actually, I believe, the #1 biggest magazine in the entire country because it has the #1 most people that subscribe to it. And it is for patients over 50, and it's national, right? So this is not just California. The expectation of it being medical is not being met. And here it is in the article, the #1 part of that article. Older people think that there will be a prescription waiting for them at the dispensary, like at a drugstore. But it's not. The doctor gives you some recommendations, not a prescription. Then you're on your own. Right? This is really intense. This is a 72-year-old retired salesman that is saying this. Why is it that we're not providing patients with more support? And I wanted to allude to this really quickly. This whole idea of this being a recommendation versus a prescription and the verification systems out there. Writing a recommendation is simply a key to the store. All it does is unlock the store and you can get whatever you want from the store. It's not a specific, you get Synthroid, 75 micrograms once a day, take 30 minutes, an hour before you eat, first thing in the morning. That's not the directions. The directions is you have a pre-existing diagnosis that you could possibly use cannabis for. That's it. That's all that we're saying on this darned recommendation, right? We're not giving people much more than that. So this is why it's part of the problem. It's not equal to a prescription that gives clear chemical names, ratios, and indications. So part 2 of this article, what are number 2 and 3 here? Dispensaries carry a dizzying variety of products. It is overwhelming. There are now vape pens, vape oil, vape for flower, inhalation, sublingual oils, edibles, a variety of dosing and ratios. I'm going to get into more here. There's rectal suppositories. There's vaginal suppositories. There's topicals. You can do this by G-tube. Did you hear that? By G-tube. I have I'd say about 2 to 3 dozen patients who have G-tubes and use this by G-tube. Because guess what? It's better than taking an opiate for their pain. But there are so many options, and people are so frustrated because they don't know what to do, and it's expensive. And like I said before, dosing is much more potent now than it was back in the 1970s. We're no longer dealing with flower that's 3 to 6%. We're upwards of about 30% at this point in flower, and the rest of the product lines as well. We're seeing just general increases. So what are patients looking for? It's very simple. They're not looking for a rubber stamp anymore. They're not looking for someone just to okay smoking pot. They can do that now in California. They can walk in on their own and get whatever they want. They're looking for someone who's familiar with the effects and the side effects of the medication for their specific diagnosis. Those of you who recommend here in the room today, the dose for CBD for epilepsy and for seizures is dramatically different from the dose for pain, right? If you have an arthritic knee, you don't need to take 10 milligrams per kilogram of CBD per dose. You can take 20 milligrams, and that's it. You could take 50 milligrams, but you're not taking it 3 times a day around the clock for the rest of your life. They want assistance with mode of delivery and dosing strategies. They want assistance with co-management of the medication, not just that they're on, but as we've mentioned here earlier today, there are other medications, there are other pharmaceuticals. They want to know how these things interact. They want validation or rejection of what they're reading online. Is this really good for me? Should I be taking this? Is Delta 8 the answer? Is it not the answer? My son is now using it. What should I say to him? And remember, medicine only works when it's dosed and administered correctly. I saw an article recently on postoperative pain for orthopedic procedures about cannabis, and it claimed at the end that cannabis doesn't work. And I scratched my head and I thought, well, how did they come to this conclusion? So I read through what the different patients were using for their postoperative pain. One patient used 1 dose of CBD 1 time. One patient used a topical cream. One patient smoked something. So there was all of these different varieties. We would never accept that as a regular medical research journal if we knew what we were talking about. But so often the people who are writing these articles don't realize that all these different things are actually very different. It's like saying Tylenol versus Vicodin versus a topical ketorolac, right? They're so different from one another. You have to be able to compare apples to apples and oranges to oranges. So I think somebody else showed this already this morning, but the legal perspective. And I brought this up earlier, and I want to clarify a bit. Oftentimes, I think people are very afraid, and every lecture I've given, every talk I've given, oftentimes there's a lawyer in the room that also gives a talk and scares the bejeebus out of all of my colleagues. So I want to really clarify this. Is this worth losing my license? 2 years ago, I had the Medical Board of California come down to Los Angeles and give a talk about medical marijuana and how people would lose their license when they practice recommending medical marijuana. And this was their conclusion. If you apply medical standards to your medical practice, don't be worried. What does that mean? What are general medical standards? Well, evaluate the patient, ensure an appropriate diagnosis exists, or a pre-existing diagnosis. Make sure you write down a treatment plan and document this, right? Plan on seeing the patient again. Don't plan on this being a one-time kind of one-shot episode. So I wanted to show you a couple of people who got in trouble and actually delve into it. How did they get into trouble? This was a California-based physician who got into trouble, and this is a bit of a salacious title, so I do want to read it so you understand. Doctor's license revoked for treating 4-year-old patient with cannabis cookies. It sounds pretty like, oh my God, obviously, like why would anybody treat a 4-year-old child with cannabis cookies? That seems like you're drugging them, right? That wasn't exactly what happened. This physician was seeing a patient, and the patient's son was also present, and the son seemed to be bouncing off the walls. Did not have a pre-existing diagnosis. The physician is not typically a diagnostic physician for psychiatry or pediatrics or anything near the sort, but decided at that point that the patient, the 4-year-old, may have ADHD or bipolar disorder. Right? Exactly. I'm hearing the whispers already. That's not appropriate. That is where it stops. That should have stopped this physician at that point because that's not appropriate. You don't diagnose a 4-year-old with 2 very extreme diagnoses that you never diagnose in the first place, right? You don't know the standards, you don't apply anything. This is not something I would feel comfortable with. And then what did this practicing physician then decided to recommend cannabis products. The cookies seems like a bit of an extreme kind of title issue. So that was the problem here. And I can see that everyone in this room, jaws slack, seemed to be on board that this was an inappropriate situation. So the problems. So what are the other problems that we're seeing? Mass approvals or rubber stamping. What would you consider the max number of patients you see in a day? Who sees a lot of patients in one day? Anybody? Anybody see 5 patients in a day? Yes. 10 patients in a day? Yes. 20 patients in a day? All right, I see one more. 30 patients in a day? Right, we're getting to high numbers here, right? No, just anything. So, and in a day, how many patients do you see? 30 patients. 40 patients? 50? At the heart of COVID. And was this doing COVID patients? Okay. So this next doctor got suspended in Michigan for seeing 60 patients a day for a long time and rubber stamping cannabis approvals for 60 patients a day. That's, I believe it was 22,000 cases in about a 12-month period. That means that this individual was not going on vacations, not taking holidays off, not going home, I'm guessing, before midnight, right? Like, I mean, how is that possible? And for those of you who were in the room when there was a physician here sitting in front of me, he's no longer here, he remarked that the DEA came and raided his offices, right? It kind of put a little bit of a scare and panic in a lot of us, and I went and asked him about it. He was the top 3 recommender in the state for cannabis. He said that he was writing probably similar numbers of cannabis recommendations. That's rubber stamping. That's not seeing patients. You can't document that well. No one can. It's physically impossible. So these are the cases that people are going to come and stomp down your door and question what you're doing. This is not good medical practice, right? There's also situations where the doctor isn't even evaluating. Sometimes somebody else is doing the evaluation. Sometimes no one is doing the evaluations. They're just taking a credit card and sending you a recommendation. There's little to no medical documentation. That's when the medical board is going to come and be upset with you. That's when the DEA is going to get involved. This is when you will get into legal problems. If you are doing things to support patient care, documenting appropriately with appropriate medical diagnoses, you shouldn't have any issues. So, why are we having this conversation? Why are we even bringing this up? What is your perspective for all of this? Are you going to tell all of your patients who need medical marijuana or recreational marijuana or whatnot? Are you going to tell them to just fly to Colorado every time they need something? No, we need to be involved. The community needs medical education. You need to be the smartest person in the room when you talk about cannabis. The community relies on the doctors, the nurses, the medical staff to be knowledgeable about this so they can come and talk to you. We need to be able to guide the government and taxes and laws and costs in order to help patients best. Because at the end of the day, the people who are making the rules aren't always looking to us because we don't know what we're doing. We need to help guide patients and their families and to preserve our patient-doctor relationship. This has gone to hell in a handbasket, quite frankly. People online hate their doctors. Nobody believes in vaccinations. Nobody believes in their doctors are doing the right thing. Everybody thinks that pharmaceutical companies are paying us to write more opiates. Disprove them. Get your patient relationship back. And the only way to do that is to be honest, to have thorough conversations with patients, and to be knowledgeable. We also need to be able to protect our patients, both the medical and the recreational patients. We have to be able to tell them, hey, that may be a little too much for you, especially because you're taking it on top of the Ambien and you're taking an opiate on top of that. We need to recognize that there needs to be limitations put in place, whether it has to do with Delta 8 or the next new fad that comes along. And we need to be knowledgeable about the medication interactions so that ultimately we can have better patient outcomes. That's the long and short of all of this, is that we're looking to get better patient outcomes, healthier patients who are happier. So, best practices. We're getting towards the end here, so sorry it's taken a little while. I'm in pain. Can you give me some medical marijuana? We're against it. It leads to unintended consequences. I'm going to write you for some oxy instead. Right? Isn't that the essence of the issue at hand right now? Number 1, patients are overwhelmed, especially when they're sick and in pain. When they get diagnosed with cancer, there is about a 70% chance that they are going to be depressed, anxious, and sleeping very poorly. It's not a time to tell them to go Google and figure out their own cannabis regimen. Don't expect to just rubber stamp it. There's an alphabet soup out there of cannabis. We spoke about this very briefly. THC, THCA, CBD, CBDA, CBN, CBG, THCV. I can keep going. I mean, it's kind of sad how ridiculously large the options are these days. What are the ratios this patient should use? Is it going to be a CBD dominant or a THC dominant? Patients show up to my door and say, I'm taking CBD. And I look at the bottle and lo and behold, it's a 1-to-1 ratio of THC and CBD. That is a THC dominant. They need to understand what they're taking. What are the different modes of administration? I already spoke to you about this, and I heard a little bit of gasping. I want to go over this really quickly one more time. Rectal suppositories and vaginal suppositories can be helpful. Patients are now making them on their own. They can find out the recipe online, and they will use it unless you advise them for or against it. There's few times when I do recommend this, and they usually have to do with rectal and vaginal cancers. And when they're having pain, I had one patient with a rectovaginal fistula who couldn't tolerate her chemo anymore. We started using both rectal suppository as well as an oral dose, and with both of those, she was not only able to tolerate her chemo, but she healed her fistula. She's still alive today. Topical. We had a big debate earlier. How many of you in the room like topical products? About half. I'm a big fan of topical. I think it's a great way to introduce cannabis to somebody who otherwise doesn't really want to touch the stuff, right? It's a great way to say, it's okay, I respect your boundaries and the fact that you don't want to use THC or CBD. Why don't you just try this cream on your arthritic knee? It's a really easy way, low-hanging fruit, to meet patients where they are. Be prepared to learn from your patients. I think you've heard this over and over again. Our patients are much wiser than we give them credit for. They are much more well-versed on this than we give them credit for. And guess what? Sometimes they have more time to peruse the internet about their particular diagnosis and how it relates back to cannabis. So they're going to do a lot of the legwork for you. So listen to them. Be honest, answer questions, and present the data. They're going to ask you a lot of really hard questions. What are the long-term effects? Will this affect my brain? What about my short-term memory loss? Be honest. You may know the answers. You may not know the answers. Your answers may be right and they may be wrong. But guess what? I bet they will change in about 6 months, because every time I turn around, there's new research out there. And every time I turn around, it's usually more positive than negative. But the point is you have to be honest and straightforward. You know why? Because it's not a medication I made, and it's not a medication you made. And guess what? I don't profit off of it, and neither will you. Or you shouldn't, at least. As physicians, our job is to counsel patients, not the medication. We're not advocates for medication, right? I don't get paid from Viagra every time I write for Viagra, but I write for it anyways, right? If patients need something, that's our position, is to be guidance and to be counselors. And the side effects of all of these medications need to be discussed, right? It's part and parcel with our job. So we're getting to the end here. So this is as simple, the idea of cannabis can be as simple as you want it to be or as complicated as you want it to be. Do you want it to be a hand-holding 45-minute event? Do you want it to be 15 minutes in and out? It's your choice. But I'm going to assume that you are the most knowledgeable person in the room and that you are the doctor and the pharmacist. How to take it with food, without food. Is it going to give me a stomach ache? Is it going to make my constipation worse? Am I going to stay up all night? Am I going to get high or stoned? Can I drive with it? All of these questions, you have to be prepared to answer them. Provide patients with specific recommendations based on science and medical research. You've learned a lot here today. Implement it. If you have questions, go online and Google it. Go on PubMed and look it up. If you have questions, reach out to myself or somebody else who you feel comfortable asking questions from. You're always going to be able to defend your position in front of a medical board if you have a position. If you base that position off of good science, off of good research, you'll be able to defend it. And there has been no negative legal outcomes for supporting medical patients. All right. So lastly, my practice 5 years ago versus now. When I first started in medical cannabis, people thought I was crazy. It just went recreationally legal. And people were like, why would you open up an office? They can just walk right in and get whatever they want, my parents included. They thought I was nuts. What ended up happening was something that no one expected. Patients came in because they wanted counseling. They wanted more information. And at first, I wasn't prepared to give it to them. At first, all I did was say, you can use it. This is what it's indicated for. You can try this or that, and we'll see how you do. Now, I dose adjust their medications. I ask them to decrease their Ambien as they increase their THC. I tell them to break their pills in half. I tell them to come back and check back in with me. I won't prescribe their pharmaceuticals because I value their relationship with their existing practitioner, and I want them to value their relationship. but I do recommend how to decrease other medications. Why? Because they'll do better. They need guidance. They didn't go through medical school. They didn't go through residency. They don't know what the difference is between Tylenol, Motrin, and aspirin. But you all do. So advise them on it. Tell them how to use this. Tell them all the nitty-gritties of it all. Tell them that they can skip their aspirin dose if it's appropriate. Tell them they can skip their Norco dose if they feel up to it. Tell them how to do it, and then check back on them and do it again. So what's next? You can basically adjust your office practice to the way you want it to be. You can decide if you're going to take cash or take insurance. You can decide how much time you want to spend with patients and the level of discussion you want to have. You can do it via telehealth. The beauty of telehealth and the pandemic was that it made it more like a reasonable option for a lot of people. And you can access more individuals and more patients that way. You can use it as an adjunctive treatment, like many of our practitioners here today are doing. It doesn't have to be your entire practice. It can be part of a holistic treatment plan, or it can just be part of your Western style of medicine. You get to choose. This is just another tool for your tool belt. Have options. We don't have just one blood pressure pill. We have about 10 to 15 of them. It's a lot of options. Why not have another one for pain or another one for nausea? It's a benefit, not a hindrance. So what's next? A lot more research. This is a very crowded slide, but I wanted to show you that there's being millions and millions of dollars being poured into research right now. The NFL just paid UC San Diego to do research on athletes and opiates and pain, okay? And cannabis, sorry. They want to see these positive outcomes, finally, right, after decades and decades. UCLA has gotten about $7 million in grants for arthritis research, for sleep, etc. And I believe UC San Diego also got about $5 million 5 years ago to do autism research that they're just starting to leak out the data of now. So we're going to start seeing that coming out as well. So Society of Cannabis Clinicians, this is an organization I've spoken about at length today. This is an amazing group that is designed for medical education. It supports nurses, physicians, other supportive healthcare providers, and the goal here is just to educate you on more details about the plant. All right, I think I've spoken enough. Thank you so much.